This segment's going to be a little different because we have co-presenters here this morning who are able to really well illustrate the partnership that you can create between primary care and behavioral health. It's a partnership I think you'll find yourself wanting to emulate once you see how they've done it. Dr. Matt Chan grew up in Vermont and went to school at Tufts in Boston. He came here to Oregon for OHSU family medicine residency and stayed because he loves Portland so much. He says he also loves to bake bread, but that doesn't always work out as well as his practice does. So we'll have to give him some tips if we can. Kyle Higgins, LCSW, earned a master's degree in social work from Loyola University in Chicago. As a behavioral health consultant, he brings his experience in mental health to primary care to support patients within a team-based approach. Areas of interest include managing anxiety, healing from trauma, and recovery from addiction. This morning, Matt and Kyle are going to walk us through the successful partnership they've built between primary care and behavioral health and show you how to do the same thing. They use a trauma-informed approach that yields impressive results, and we'll be letting you in on some new free treatment resources you're definitely going to want to explore when they're done. Please welcome Dr. Matt Chan and Kyle Higgins, LCSW.
Hello, my name is Kyle, and I am a behavioral health consultant at the Family Medicine Clinic here at OHSU at the South Waterfront. And I'm presenting today with Matt. I'll let Matt introduce himself.
Hi, my name is Matt Chan. I am one of the assistant professors in our family medicine department, working up at Scappoose Clinic, and I have the pleasure of presenting today with Kyle. And together, we're going to discuss a little about alcohol use disorder in primary care, and more specifically, what are some of the barriers? How do you work with behavioral health to, promote treatment in alcohol use disorder? And then maybe some strategies in harm reduction.
Yeah, excellent. So let's go ahead and go on to the next slide there. So Matt and I don't have any disclosures today. We want to thank CareOregon for inviting us to participate and share just some approaches that we use in terms of supporting folks struggling with alcohol use disorder. So we're going to kind of dive into a lot of different topics here as it relates to that. So this is a quote that I came across while kind of preparing for today's talk. And it says, primary care providers are the most likely to have contact with patients who are struggling with substances, yet we have traditionally avoided that responsibility. I think this quote kind of highlights the importance of primary care being able to meet the needs of patients struggling with substance use disorders in general, but also more specifically alcohol use disorder. These are your patients already, so they're coming in with these challenges, and it can be really important that we have conversations about what they're struggling with and have ways to support them and feel confident in our ability to support them and help them sort of treatment plan and identify the resources or the needed treatments and supports. So we're glad you're here today to talk about that. So I was going to talk here for a few slides about the DSM diagnosis of alcohol use disorder. I always like to kind of highlight the difference between the DSM-4 and the DSM-5. It was previously most substance use disorders, or all substance use disorders, were seen as this difference between abuse and dependence, which wasn't like, and no label for substance use disorders or for diagnosis is always perfect. But they've switched from seeing it as a abuse versus dependence and a use disorder that kind of happens on a spectrum or on a continuum from mild to moderate to severe, which in my opinion is a more helpful way of looking at it instead of trying to differentiate whether this is abuse or dependence, which that can get a little cloudy or a little muddy. Having more specific ranges within a spectrum can be a little easier to sort of articulate to patients or to talk about kind of where they fall on that spectrum. And so somebody with a mild substance use disorder would have to meet two of the symptoms. Somebody with a moderate would be 4 or 5, and then somebody severe would be 6 or more of the symptoms. So let's look at those symptoms real quick here on the next slide. So this is taken straight out of the DSM, right? So in order to confirm a diagnosis of alcohol use disorder, like I said, you need to have at least 2 for mild. And I'm not going to go through all of these. A lot of these are probably familiar to everybody, or things that we kind of talk about or think about when talking with patients or our coworkers about patients. So it's really just about, the desire to use, the inability to stop when trying to, the impact it has on life, right? So work, social relationships, and continuing to use despite those problems. And then the tolerance piece, right? So tolerance is defined by either of the following: a need for more, for markedly increased amount to achieve intoxication, and a markedly diminished effect when continued to use. So that can also be a sign that somebody is, as they're increasing their use, that they're having struggles moderating or not using if that's their goal. Um, so let's look at some of the numbers. We have quite a few numbers in here. And a lot of this data comes from like SAMHSA, who does a yearly survey on alcohol use trends, or substance use trends in the country. And so as some of the more recent surveys, among adults 18 years and over, 25.5% reported engaging in binge drinking. Um, I wanted to highlight that because I often think that what we see in primary care is more of a binge pattern of drinking. We do see those more chronic users, heavy users, daily users, those that are that we're concerned about, like complicated withdrawals. But we also see those folks that are more in a sort of like what's labeled often as like a functional alcoholic, right? Or somebody who goes to work and manages most of their responsibilities, but several times a week even, they may be drinking 10, 12 beers or something like that. And so in primary care, I found that we often see folks that have this binge pattern of drinking, where they can go 2 or 3 days without drinking, but then when they start, they can't really stop. They have a hard time sort of moderating that use. We see here, estimated number of deaths related to alcohol use, or alcohol related to alcohol causes. This is a really hard number to sort of pin down because people are not, people are dying from other health complications, but it's often related to their drinking, but it doesn't sort of get labeled as that on maybe a death certificate or in reporting. And so that number is probably far higher than 88,000, but that's just sort of what we've estimated, which is twice as the number of deaths per year related to opiate overdose deaths. So I just kind of wanted to highlight that, and that this is a significant impact on health and the healthcare system. And it's the 4th leading cause of death in the United States, which is, right up there with some of the, heart disease and smoking related deaths and such. So here's an infographic that we included. I like to point on here, just in terms of the dollars per year that is related to the use of alcohol, in terms of whether it's medical expenses or workplace productivity or the criminal justice system. We're spending a lot of money on the effects and the impacts of alcohol on society. I also want to point out here the standard drink size. I know most of us probably know what a standard drink is, and we have a good sense of, a 12-ounce beer, or a 5-ounce glass of wine. But our patients may have a different standard. They may see what they drink as more of a standard. When we break it down into the numbers, they may actually be drinking twice what they think they are. And so sometimes I find that helpful to have a conversation about that. Talk about, it says here 12-ounce beer at 5% alcohol. And we know that many of the beers, especially in Oregon, are more than 5% alcohol. And one beer of 8% is really like, if you're drinking a 16-ounce beer, you're really drinking about 2 beers, equivalent into the standard drink model. And so I've had patients tell me, oh, I've only had 3 drinks, but then I find out they're drinking those like really big 22-ounce drinks, right? And, we can talk about that in terms of harm reduction later, but I think that it's important to just kind of help them have a conversation about like what is excessive and what is within the healthy range if they want to try and moderate their alcohol use. This one kind of just speaks for itself, but I thought it was important to include. I think some people might find it surprising that Oregon ranks 8th nationally in the per capita cost, and nearly $1,000 per Oregonian, which is, quite a bit of money when you think about it. That $1,000 per person could definitely go to other causes that would gladly take the money in terms of education, or even other programs to support families. So we're going to talk a little bit about screening, intervention, and treatment. And this slide kind of talks about the treatment process and how it can work, but it's slow, and we need to be patient. And the one thing too I would encourage people to think about, or maybe challenge people to work with, is their concept of what success is. We tend to think it as sort of black and white, or all or nothing, right? Either you're drinking or you're not drinking. And if you can sort of rethink your process, or your idea of what success is, you can view your patients in a way of progress or making change that is improving their health and improving their outcomes. That said, when we look at the numbers, 15 million Americans over the age of 18 are diagnosed with or living with alcohol use disorder, but only about 7% of them receive the treatment that they need. So at a very basic level too, the folks that need treatment aren't accessing it. And we would probably see improved outcomes if people were accessing the treatment that they need. We also see here that in surveys, people found that they prefer to engage with a primary care setting by almost 40%, compared to 25% who would traditionally would be okay accessing treatment in a traditional treatment center or setting. So again, kind of thinking about that quote at the very beginning, people are comfortable coming to their medical home or medical provider talking about these things more so than walking into maybe a detox center or an outpatient treatment center. There's less stigma involved in seeing a medical provider about it, and they feel comfortable. They have a relationship with their provider and their doctor, and it's a place where they can go and talk about something that maybe they've struggled to talk about or have never ever talked to anybody about before. So just wanted to highlight that we are sort of on the front lines of that when of treating and diagnosing substance use disorder, as people are coming into our clinics with them. So this is a brief sort of overview of the ASAM treatment levels. ASAM is fairly complicated. It could be a class or a workshop in and of itself. We think about ASAM in terms of level of care and within several domains. There's 6 domains within ASAM. And it's a model of sort of assessing that's probably more useful for treatment centers specifically. But I thought it was maybe helpful just to kind of see like where people fall. And I kind of equate it a little bit to the mild, moderate, and severe categories within opiate use disorder, right? So somebody in a mild category would be in this like early intervention, maybe even an outpatient program. The moderate is going to be more of an intensive outpatient program potentially. When we're looking at intensive outpatient versus like an inpatient or a medical detox, we're looking at potential for relapse prevention. We're looking at potential for complicated withdrawals and needed to be in a medical setting to withdrawal or detox. And so that's the severe folks are going to fall more into a residential, probably with an initial medical detox. So this is just kind of a way of looking at, it's the language that treatment facilities use in terms of assessing and determining what level of care somebody's appropriate for. So when you're sending somebody to a treatment facility and they're getting assessed by the providers there, they're using this language to refer them to the right level, appropriate level of care. So I'm going to hand it off to Matt here, who's going to start off by talking about the PCP and the primary care role.
All right, thank you, Kyle. So, as Kyle was mentioning before, we're definitely on the front lines of taking care of people with unhealthy alcohol use and alcohol use disorders. And a lot of times we'll do that with screenings, like the ESPER, which we'll get into more detail in a bit, and then followed by referrals. And a lot of times it's helpful, if, I'm grateful in the clinic I work at. I know a lot of OHSU clinics have integrated behavioral health team-based care. So our behavioral health people are embedded within the clinic alongside the providers, and sometimes with pharmacy teams as well. And with that, it allows us to really help provide kind of this full spectrum wraparound care for comorbid health conditions. Because a lot of times the results and consequences of alcohol use are fairly extensive, and it's not just medical based, right? There are social issues, financial, legal, a lot of things that go along with those chronic disease management. So I'm going to just throw in a brief case. We're not going to rely on it too much throughout the lecture, but I think it just helps establish the general flavor of what we're going to be talking about with the screening. So there's a 39-year-old gentleman, new to established care, comes into the office, and the first thing he wants to talk about is his recurrent gout. No other medical history that he thinks is relevant. Partway through the conversation, you ask him about his alcohol intake, and he tells you that he drinks upwards of 6 beers a night, every night. So obviously most providers would, in the back of their heads, suspect maybe this guy has unhealthy alcohol use or alcohol use disorder, and wanted to investigate that further. So we'll still quickly through it. How do you do the screening? Now, when people come to see you, right, they present in many different ways, anywhere from kind of the straightforward, someone's acutely intoxicated, pretty easy to do, to a whole various amount of presentations, including mental health disorders, depression, anxiety, fairly common co-occurring mental health disorders, any complications or sequelae of their alcohol use. So whether that's something that you can see under skin, something you can tell, based on their, liver, kidneys, or lab work, things like that. And then actually probably the most things I see are somatic complaints or pain complaints. So people, thinking that, oh, I have this one thing, but it's actually the underlying driver is alcohol use. Or simply just asking for help too. Now the USPSTF, which is the United States Preventive Service Task Force, they release guidelines for just about every single screening thing that we do in primary care. In terms of alcohol use disorder, we're looking at adults 18 years or older and pregnant women. They rate it a grade B. So just quickly, the grades go from A, B, C, D, and then I. A being like everyone should be doing this thing. B is kind of like there's moderate evidence for this action. C is kind of plus or minus, maybe some weak evidence, and D is definitely like we shouldn't be doing this. I is also kind of like an indeterminate. So for alcohol use in adults and pregnant women, they gave it a grade B. For screening for alcohol and providing that brief behavioral counseling intervention to reduce unhealthy use. I think it's interesting that in terms of adolescents aged 12 to 17, they gave it a grade I. Not that by no means does that mean that we shouldn't be screening for alcohol use in teens. It just means that the evidence has not been firmly established as it has been for adults. And I'm going to mostly be focused on screening for adults in this segment. There's certainly other screening modalities we use for adolescents that we won't be getting into too much detail today. So a lot of you are probably familiar and have some form of screening for this already in your clinics. This is our OHSU Family Medicine screening questionnaire. It's a single screening questionnaire. And would just, just separate between men and women. And if you just screen positive just for that one question, it actually has a really pretty high sensitivity of 82% and a specificity of 79%. So just as a refresher, right, a sensitivity meaning like if someone has alcohol use issues, in an ideal world, everyone would screen 100% positive for that, but that's not always the case. But in terms of one single screening questionnaire, 80% is pretty good. Now, usually you follow the single screening questionnaire if they screen positive with the audit, which is the most commonly used full question screening that we do for alcohol use disorder. And again, most of you are probably very familiar with this, so I'm not going to spend too much time on it. But you can see there's 10 questions, all ranking from 0 to 4, and based on their total aggregate score, puts them into a risk zone. So on the right side of the screen, you'll see that there are 4 zones: low risk to severe. And depending on which zone they fall into, suggests what action you take. So if it's low risk, then you might just do kind of a very quick, brief education about alcohol use. If it's very, very severe, that one's also really straightforward. They probably need some higher level of care, like Kyle was talking about, something, inpatient or detox treatment or something along those lines. And then in the in-between, the risky and harmful is where primary care really can make a really big impact in terms of our brief interventions. So let's pretend our patient did their questionnaire, went through and circled everything. If you add up everything, this would have them fall into the risk zone number 2, so the risky zone. So again, just with looking at the audit, when compared with the brief screening questionnaire, that 1 to 3 question first screen, there's a pretty good sensitivity and specificity for the single screen compared to just using the full audit for identifying unhealthy use. And using the audit, it tends to be better if you're using the standard cutoff of 8 or higher. So, right, you're sitting there, you got 15 minutes, 20 minutes, maybe even less at this point. You spend a lot of time just talking to a patient about their medical issue. And so how do you complete an intervention, right? So this is where the ESPER comes in. And this is, right, a reminder, is a clinical framework to help guide this discussion in terms of guiding someone through their alcohol use and maybe some motivational interviewing changes that they can make. And again, it gives you a guide to provide objective evidence and consequences of their alcohol use without being judgmental. So this comes from the CareOregon website. These are just large, they come in either small pamphlets or they come in these larger size papers. And what you do is once you get the risk score, you take a look at the risk score in the pyramid on the right, and you determine, oh, they low risk, high risk, harmful, or severe. You can make recommendations under safe drinking limits with the table on the left. And then below, you can highlight some of the long-term complications of alcohol use disorder. And so using this, again, you can use it, all of it, just parts of it, just to help guide your conversation with the patient. And below is this thing called the readiness ruler, which promote change, assess and promoting change. Now, that first page is usually the front part of it, and so that's the thing I'm usually showing to the patient. And on the back side is the framework of phrases to help guide your brief intervention. I remember early on when I was starting to do experts, it felt really awkward to try to transition something from the agenda that the patient had to the agenda that I wanted to do, which is to address their alcohol use. And what was really nice when I first learned to do the expert was these prompts on the back. Something as simple as, thanks for filling out this form. Can I talk a little about your substance use? Was a really helpful segue into their transitioning to the expert. And what's nice is that most of these questions are open-ended and meant to help promote the change through the patient's goals and values and motivations, and not necessarily through your own and what you want for them. Separately at the bottom, I just want to point out they also have a section for billing and coding, which again, we're not going to get into detail, but for the clinician who wants to learn more about that, that's also at the bottom of the screen. So like I said, open-ended questioning help to drive the patient's patient-driven change. And so there's this concept of auras, where you're using open-ended questions, you're using affirmations, you're doing some reflective listening, and then maybe taking that and summarizing it back to the patient. And Kyle's going to go through some of this a little bit later as well. Lastly, we'll get to how do I leverage my behavioral health colleagues and experts in the clinic to help maybe do a warm handoff. But if you're perhaps just in your own clinic, maybe you don't have ready access to a behavioral health person, the Oregon Health Authority has compiled a list of treatment places, treatment centers that you can reference in this provided directory. So we're happy to send out the link further if people want to save this. All right, so I'm going to transition back to Kyle for the behavioral health portion.
All right, let me get myself off mute there. Okay, thanks, Matt. Yeah, and so, so some of us, some clinics may be more integrated and have behavioral health located in the clinic, somebody to access in the moment when the patient is there. And so that's what I'm going to talk a little bit about too. I might be biased in a sense that I feel like the BHC plays a really essential role in sort of supporting patients who are coming in with substance use disorders. At a broader sense, I find that it's really helpful for allowing more time, right? So as Matt was saying, you have 15, 20 minutes for a visit, you're going through the SBIR, or maybe they've already completed the screening before you come into the room. That doesn't give you a lot of time to have a really important conversation. And so that's where getting behavioral health involved can be really helpful. It gives the conversation more time. You can warm handoff. You can go on to your next patient, even circle back around if you need to before the patient leaves to kind of close a loop on the treatment planning. But it allows for a more comprehensive visit for sure. And so the behavioral health support, or the behavioral health consultant's role, is to support the SBIRT process, right? Help with the screening and the intervention and the referral to treatment. Um, we also see, I also see our role as, if nothing else can be done, introducing the patient to the behavioral health team member is a great start, right? It is an intervention almost in and of itself, because you're building a relationship with somebody who can follow up and provide additional support. I see this as sort of like planting the seed. If they're not ready to make any changes right away, just sort of beginning the conversation, introducing them more supports within the clinic and where they can reach out to if they want to have the conversation or kind of move forward, is sort of planting the seed for change. Um, our role is also to help clarify goals and treatment planning. That is trying to, determine that level of care, right? Or figure out where the patient's at and meet them there and start providing guidance or maybe resources that they can look into. Um, Build the motivation for change. So I feel this is essential for everybody, right? Not just the behavioral health provider, but also the PCP, the RN if they're involved, maybe even a pharmacist, right? Everybody's sort of helping the person identify what their goals are. And, when I work around motivation for change, I do a lot of the questioning about what's important to them about changing, and then sort of reflecting that back to them. And then if I notice any discrepancies, I'll identify that as well, right? So I'll say something like, it's really important to you that you drink less alcohol. But it's really hard when you go out with friends to not go overboard, right? Or you're worried about losing your friends, or it's such a social thing for you. You're worried about losing that important part of your life, right? So you're identifying why it's important to them, but then you're also noting that there's things in them almost that they get out of it, right? Or there's things that are really important to them that they're worried about losing. Um, and so that can be really helpful. I think also just kind of starting where they're at and kind of identifying what their goals are. I'll often, when the PCP warm hands off to me and is like, oh, this is John, and he's looking to make some changes in his alcohol use. And we talked about how it's really important that he stops drinking. And then the provider will step out, and I'll sort of like clarify that with them. And I'll say, how important is it to you that you stop drinking? Maybe their blood pressure is more important to them and they see that as the central issue or the primary issue, and drinking is contributing to their high blood pressure, but that's less important to them. And so it's sort of understanding where their importance is, and then also where their confidence is in terms of making a change. So that's really important aspects of motivational interviewing as well, sort of the importance and confidence scales. I'll ask somebody on a 0 to 10 scale, how confident are you that you can make these changes, or how important is it to you? And so that can also be really helpful to kind of identifying where they're at and meeting them there. And then it also kind of points you in the direction of maybe where to start some of the conversation. Promoting harm reduction principles. I think this is also a really important role of behavioral health providers. Not everybody's goal is to abstain. And when we define success by abstinence, especially in primary care, we're going to find that we're not having a lot of successes, and that's just kind of a frank assessment of We're not a treatment facility, so we're coming in, people are coming in for their medical needs, and we're talking about alcohol use. And if we're strictly focusing on abstinence, then we're not going to see the progress that maybe we feel like people need, but they can still reduce their risk. They can cut their drinking in half, and that's definitely success in a lot of cases. One patient I've worked with in particular, our harm reduction approach was um, to not drink at home. And so he would only go out to drink, which caused other problems. You know, it was financially expensive. You know, it kept him out too late at night. But he had a limit, and he would only drink about 3 drinks. You know, go to happy hour, have 3 drinks, and go home at at a decent hour. But he wouldn't drink at home. And every time he started drinking at home, he would, you know, instead of having 3 drinks, he was drinking a whole fifth of vodka, eventually leading to detox. And so, as long as he could moderate or stick within this choice he's made to reduce his risk and harm, he saw that as success. Maybe he wanted to make more change, but he was still having a hard time with that. And so, promoting and having conversations based on where somebody's at around harm reduction can be really helpful. Um, and then providing counseling or psychotherapy, that's not a central role of what the behavioral health provider does in the clinic. And in some cases, people are better served out in the community for those needs. But I do also sometimes see people back for follow-up appointments. And maybe for 6 months, we'll check in every other week or something as they're working towards their goals around either moderation or abstinence. We'll have maybe a plan around lower risk drinking, and we'll check in about that. And then when we also find, and we'll talk a little bit about this later on too, but we also find that there's a lot of other things going on, right? Like sort of the co-occurring mental health conditions, so anxiety or depression, maybe marital conflict. And you know, it's hard to know what's coming first, the alcohol use or the marital conflict, but it's definitely contributing to the larger picture. And so it also gives them a place to talk about the other things that they're struggling with, not just make it about the alcohol use, because there's often other things that they need to work on. And then referring out. So spending a lot of time referring people out to treatment, referring them out to detox, building relationships maybe with community partners. So you have sort of a pipeline of where to send somebody if they need to go. Vice versa. I mean, in some cases, we've built relationships with a few treatment providers where we can refer to them, but then if they get somebody into their care that doesn't have a PCP, they may refer back to us for somebody who needs primary care and who's discharging from treatment. And so it can sort of go both ways or be reciprocal in that sense. So if you know, building relationships, knowing, identifying who those treatment facilities are in your community, what insurances they take, is really important, because it kind of makes it easier. So when somebody comes in, it's like, okay, you would something in particular like detox or residential treatment, if they're ready to go now, we go now. Right. So we don't wait. Oh, maybe I'll go home, you know, and do this and do that. Right. Like if they're ready to go, we jump on it. And so knowing where you can send them and making that happen within like that evening, I think is really, really critical. I mean, they may need to go home and get some clothes or find somebody to take care of their pet or their cat, but we really want them to go that day, right? When the motivation is high, when the willingness is there. And so having the relationships and knowing where to send somebody can be really helpful, because if you say, well, I'll look into it and I'll call you back later this week. Later this week, there's going to be a couple more binges and things are going to be kind of back on the other track, and it makes it a little harder at that point to get them into treatment.
And kind of, if I could just echo for a
Yeah.
second too, just like, yeah, that concept of building the relationship with your community partners, you know, like I said, I think we're fortunate at OHSU because we have that co-integrated model, and you know, I can pass on my patient to Kyle, and Kyle's like the expert, and he knows all these, you know, places to potentially send someone. But for more smaller clinics or more standalone clinics, this might not be possible. So I think it's really important to have those resources just readily at hand, even if it's as simple as a phone number that you have that you would just reference to, and maybe you have someone, you know, your clinic, your medical assistant, someone make that phone call to see if that person can get in soon, you know, can make all the difference in terms of time and workflow management throughout the day.
Yeah. And I know this can be a lot for somebody who maybe doesn't have the additional support in the clinic and has a busy schedule. but sometimes even calling with the patient, right? Like sometimes that call is so hard to make. There's a lot of anxiety in that. You don't know what to expect. Maybe they've never done it before. And this is just to schedule an intake appointment, maybe for an outpatient program. There's a lot that goes into that. That's really difficult for folks. And so pulling out your cell phone in the appointment and making the call with them right then and there goes a long way to helping them take that first step. Um, and so, I encourage, if that's something that the support the patient needs, obviously they got to get themselves there and they got to do the work, but we can help kind of get them there. So as we talk about getting them there, I think it's also really important to talk about the sort of social determinants of health. There's a lot of barriers that people have to accessing treatment or to successful outcomes to either their substance use disorders or to their chronic health conditions. And so with folks in particular with substance use disorder or chronic health conditions, diabetes, hypertension, I really prioritize screening for the social determinants of health, because that's going to kind of give me an idea of what their barriers are and maybe what if their basic needs aren't being met, right? Then what we really need to focus on before they're ready to make any sort of changes, right? So somebody who has food insecurity and has uncontrolled diabetes, we really want to maybe focus on the food insecurity before we talk about lowering their A1C. And the same thing with substance use disorder, right? If they don't have transportation, if they're worried about losing their housing because they're going to go to treatment for 30 days, right, or their job, that's really something what you need to plan around. I mentioned food insecurity, access to healthcare, making sure that they feel safe and comfortable coming to the clinic. And if they're not ready to make that change that day, we want them to come back. And so we want to make it a place where they feel like they can access us and feel safe coming back to. Childcare, social supports, right? Is somebody going to be there to maybe feed their cat, or make sure that their house is okay while they're gone for up to a month potentially. Um, Childcare, IOP is really intensive. It's usually 3 or 4 days a week for about a half day, or at least 3 hours a day. And so making sure there's childcare in place, and then making sure that the program meets the literacy or the health literacy of the individual, right? Making sure that they're meeting the patient, and we are meeting the patient where they are. And intimate partner violence is, often something that there's substance abuse often involved in um, relationships that have IPV in it, right? And so maybe the partner isn't the one with the substance use issue, but their partner is drinking and becoming violent every night, right? And so the impacts of substance use on the whole system, on the whole family system, is really important to also be aware of, right? So if a patient's coming in and their provider or their partner is drinking a lot, having conversation about their safety is really important as well. I also see, here at OHSU and in a lot of our family medicine clinics, we are really focusing on trauma-informed care approaches and making our clinics as trauma-informed as possible. In my clinic in particular, I'm sort of like the facilitator of the trauma-informed care initiatives, and I speak to this a lot, and I think this is really important, that we approach people from the principles of trauma-informed care. And so some of those are creating safety, empowerment, transparency, collaboration. And you can kind of see, as we've been talking throughout this presentation today, that these principles are kind of woven throughout, right? It's kind of meeting the person where they're at, creating a sense of safety, and being transparent about why we're asking questions or why we're concerned about this or why this is important to us and maybe important to them as well. Um, so we're asking permission before we do a screening or before we review the screening. We're explaining what to expect, right? So that's the transparency piece. Approach all patients as if they have a trauma history. We approach this sort of as like a universal precaution. We're treating all patients and approaching all patients as if they have a trauma history. And then what that does is it helps us to reduce the risk of re-traumatization. And everybody's probably heard of ACEs, and we know for certain that folks who struggle with substance abuse usually have the highest rates of ACE scores, right, or have high ACE scores in general, right? So they have substance abuse in their family of origin, maybe intimate partner violence. Maybe parents were incarcerated or separated, divorce, childhood abuse, either physical, sexual, emotional. And so folks who are coming into treatment for substance use disorders have a lot of ACEs, right? Higher ACE scores. And so it's important that we understand the role of ACEs playing in the development of substance use disorders. Um, and then we want to summarize. So like in the sort of ORS conversation, we want to summarize what we hear from the patient and validate their feelings of fear and uncertainty. And validate how hard it can be to make that initial call to go to treatment or for an intake appointment. Validate um, that it's scary to make change, right? Like this is how they've coped with their anxiety, or this is how they've coped with their PTSD is through drinking. And that making those changes can be really scary because they're worried about those symptoms being unmanageable, right? We see that a lot with chronic pain too, right? If we stop taking the opioids, how am I going to manage my pain? So it's sort of a similar thing with alcohol use disorder. It's serving them a purpose. They see it as a way of helping them survive. And when we remove that survival coping mechanism, then there's a lot of fear that comes involved in that. And we have to acknowledge that fear and validate that for them. And then collaboration on treatment planning. So giving the patient a voice and what they feel is the level of care that they want, or where they want to go for treatment, and allowing them to to kind of have a voice in that a little bit, so that they can feel like they're being honored, heard, and there's some collaboration. It's not just we're not just honoring the power dynamic between provider and patient, right? Where I'm telling you what to do and this is what you're going to do. It's more like, this is what I'm concerned about, and how can I help you address that? And so that's really important. So we have a few examples here of what you can say in more of a trauma-informed approach, right? So you could open with something, and this I think was similar to what maybe it said on the Esprit card too. I would like to spend some time today discussing the results of this questionnaire. Is that okay? Right? If they say no, you can follow that up with something like, we know that alcohol use has several impacts on our mind and body, and it's important that we discuss it. So maybe, and if they really don't want to discuss it that day, you could say, well, you could say that it's important that we discuss it, so let's maybe save that for next time. And then based on what we've discussed about your recent alcohol use, there are some concerns, but you could also say recommendations, ideas, ways I can help. You can really make that patient-centered in that sort of way. I see you're worried about how this is impacting your life. This is why it's important that we explore together what is happening in different treatment options, right? So we're bringing in that collaboration. We're creating some sense of empowerment through some of these things. And I think when we reflect those, when we talk to them in this sort of trauma-informed way, they're feeling validated and safe. And that's what's really important, because what keeps people from returning to care is the fear of not feeling safe or heard in their treatment environment. So we have some examples here of a trauma-informed approach, like persons first or patient-centered language, affirming language. And so you've on the column on the left, you've probably heard a lot of these, right? We've all used them. I have used them. I catch myself using them all the time, right? So injection drug user versus people who inject drugs, drug abuse or dependence, substance use disorder, a drug abuser or an addict, a person with a substance use disorder, clean and sober, a person in recovery, or we often hear like clean and sober housing, right? Or a recovery home or a recovery environment, right? Talking to in this sort of person first language. Dirty or clean needles, we can refer to those as new or used needles. This is a big one, right? So like dirty urine, clean urine, a dirty UDS. Um, we really like to refer it into a positive or negative urine drug screening, or a drug screen confirming opiates, or a drug screen confirming whatever substances in there, right? So really that affirming language around what we're seeing. instead of sort of labeling. As you hear the ones on the left, you're probably getting a sense that there's a lot of judgment in those statements, right? And we want to reduce the judgment in a trauma-informed care approach. Medicated assisted treatment, this is one that we still use a lot, but we could just say medication treatment, or treatment, right? Treatment for your alcohol use disorder. High risk individuals versus individuals at risk of acquiring HIV or Hep C, or an individual at risk of complicated withdrawals. And just kind of identifying what they're at risk of, and naming it as that, and avoid labeling or judging the patient.
Right. Actually, one thing I wanted to, I think a lot of the things Kyle has been talking about has really been resonating with me, especially some of this trauma-informed care approach. And every time I'm with the patient and I'm getting the sense that their agenda goals are very much, incongruent with what I am necessarily wanting for them, I try to go back to this underlying thought about, okay, what kind of trauma have they experienced? What are kind of their, socioeconomic barriers that have led them to this place where they might be expressing something like either in frustration or aggression or pre-contemplation, instead of just jumping to the conclusion that, okay, this is the person that just doesn't want to do what I want them, to do. So
I'd add to that. I think that's great. And I often frame it as, instead of what's wrong with this person, what happened to this person,
yeah.
right? And so asking ourselves, what's wrong with this person? Why are they acting like this? Saying, what happened to this person? What are they bringing to the clinic today? What's happened to them that's making it hard for them to see, the right path that we all see, but they're having a hard time seeing. Yeah.
Yeah, and I would say I'd be first to admit too that I've also been guilty of using some of the language on the left column, and I think in primary care, we have been a little bit more thoughtful about transitioning the language to something that's more patient first, patient centered. I do think that this type of language on the left column is still fairly entrenched in other fields in medicine, and so I also think it's part of our almost like obligation as primary care clinicians. If you interact with other clinicians in other fields of medicine, you don't have to say like, oh, I wouldn't say that, but just kind of gently using the patient first language to demonstrate that, hey, like this is a different way to describe a person.
Yeah, that's awesome.
So just to kind of recap, because I think oftentimes you'll see a patient, maybe they're new, you start this conversation and they're going to be pre-contemplative. I think that's just the natural progression of meeting someone new, is that they don't know you, you don't have a relationship with them. And so more oftentimes than not, they're probably not going to be as keen to follow through with some of your suggestions. So as Kyle was pointing out earlier, like how do we focus on some harm reduction strategies to really, meet the patient where they're at, make sure that if they're going to continue drinking, how do they do so safely so that they don't, put themselves at risk for further injury. So the next couple of things are I thought were really good suggestions that I've been reading. This one comes from a group up in Vancouver, BC. So one of the things that they had suggested was, telling the patient that to be prepared when you drink, making sure you take your meds, making sure you're well fed, well hydrated. If they have any friends or family that they feel comfortable with, letting that person's family know where they'll be drinking instead of just, going somewhere random. If they are drinking, if they're able to mix it with something, especially like hard liquor drinks, mixing with juice, mixing with soda to help dilute the alcohol content, maybe making the drink last a little bit longer. We mentioned about hydration, knowing your limits, a little bit harder for people who are more severe alcohol users, but sometimes if they're more moderate, you can say, hey, count your bottles, count your cans. That way you can keep track of how much you're drinking through the day. And also just sticking to the thing that they tolerate the most. So, if you are a beer drinker, wine drinker, hard liquor person, maybe sticking to those things instead of doing a whole smattering of things that might get you in trouble. Drinking in safe places is really important, especially like geographically or location dependent. Up here in the Pacific Northwest, we have a lot of rainy, cold weather, and so letting them know that it's important that you can be somewhere that's warm, or maybe have resources so they can seek like a shelter where they can, be warm in the evening time, vice versa, right? In the summertime, right? Like try not drinking in the open sun, be in a shady area, that kind of thing. Tracking the drinks, going back to, again, like keeping track of the things through the day. Sometimes you can track the pull tabs of the cans, which is really nice. Or specifically telling people on the bottles, right? Like put little marks on, when, if you take a break, put a mark on it. That way you know exactly where your last drink was. And then really just, seeing if they can cut back. So if this is kind of the more traditional suggestion, right? Like if you're drinking a fifth a day of vodka, maybe try going for 3/4 of that or half of that or whatever they feel comfortable trying to cut back to. And sometimes that in and of itself can make a whole lot of difference, because you're not imposing your bias of saying, hey, this abstinence is the only way you should stop drinking alcohol. You're trying to meet them where they're at. For people with very severe alcohol use disorders, where they have had history of withdrawals, history of withdrawal seizures, history of delirium tremens that has caused hospitalizations, I actually really caution them to not stop what they're drinking like right away in cold turkey, because that can lead to actually worse outcomes. So for those types of people, they're generally someone you want to be thinking about referring, right, to a higher level of treatment or hospitalization again before having them stop drinking on their own.
I'd add to that too. There is, and I didn't think about this until you were just talking, Matt, but there's also this approach that I talk with people about sometimes. You can find a lot of resources for online with this, and it's used for both alcohol use and smoking, but it's the approach to like mindful drinking or mindful smoking. So people who tend to binge drink or who struggle to stop once they start, there's this experience of like, they just, it takes like 5 minutes, 10 minutes to drink a beer, and they don't even realize that they've finished it until the glass or the bottle or whatever is empty. And so mindfulness, incorporating mindfulness into that really slows the process down. So instead of drinking that beer in 10 minutes, see if you can spend an hour drinking it, or, half an hour drinking it, and really, instead of mindless drinking, spending some time sitting with it, noticing what that experience is like in a non-judgmental way, but just noticing it, being with it, and reflecting on it, slowing it down. And that can be a way of moderating before you're drinking 1 in 15 minutes. In an hour, you're going to be 4 back before you realize it. So this really slows that process down.
Yeah, those are great suggestions, Kyle. And I think, I put this thought in, especially in the context of what the world's going through right now with what we're seeing with racism and social injustices in the country, to be mindful about how you approach your care with somebody and how it's influenced by their gender, by their race, by their age, religion, spirituality, and how that changes the way we either, underplay or maybe overplay like their alcohol use, right? So for instance, right, spirituality, for instance, right, there are certain religions where, alcohol use is very stigmatized, or not, people generally don't drink. And so like if someone within that culture is drinking, they might even be more adverse to talking about it or revealing it to somebody in the medical profession. Certainly age plays a big role too, right? Certainly you might have more bias towards someone who's older and been drinking longer and has way more medical complications than someone who's younger and healthy and very good at being functional still, but still has an alcohol use disorder. And certainly, race has been a big controversy going on in this country. And so thinking about, how are your biases towards different ethnicities and how that plays into your care. As an extension of that, what about non-English speakers? I think this often comes up in some of our community clinics, especially in Portland. The audit, as we have already gone over, it was created by the World Health Organization, and actually has been validated in a lot of several cultures in different languages. A lot of the original samples and research subjects were in different countries like Australia, Bulgaria, Kenya, Mexico, Norway, included in addition to the US. So if you go to this website, auditscreen.org, and you're looking for the audit in different languages, I mean, it's been translated into a multitude of languages, which is really nice. There are a couple other ones that you can consider using. The Assist, which is just a different screening questionnaire, also developed by the WHO, supposedly a culturally neutral tool to be used in primary care. It's a 8 quote unquote question screening questionnaire, although within each question there are multiple sub questions, so it can be a little bit more cumbersome. It's not something I've personally been seeing used in primary care clinics, but I think it's another option that exists for people. And then a traditional teaching that there's the CAGE questionnaires, right? So, has anyone asked you to come back? Has anyone ever been annoyed about your drinking habits? Have you ever felt guilty about it? Or have you ever used a drink first thing in the morning called the eye opener, so CAGE? It's shorter, easier to translate the questions probably into different languages, but it's not quite as good as capturing people with just mild or unhealthy alcohol use. It's better for people who have like a more severe usage habit. So just quickly returning to the case. So this person, again, came in with gout problems, and then you found out that this person probably had some unhealthy alcohol use habits. The person recognized when you brought it up that some of the medical issues that he was experiencing was probably related to this drinking habit, but he didn't want to stop drinking completely, right? Very common scenario. So instead, he agreed to try maybe reducing his intake to 3 beers per night. And then you planned on following up, the next office visit. So, I think going back to all the things we've been talking about, the nice summarization would be, something along the lines of like, this person was contemplative, maybe recognized that they're, had the aha moment that, okay, maybe some of the things I'm doing are bad for me, but didn't want to stop completely. And that's okay because, right, that's part of the thing about primary care in general is establishing that longitudinal relationship. So you can have this guy come back and maybe keep moving the needle a little bit forward. And so when we do our Q&A, we'd happy to hear about more harm reductive approaches from other people too.
Yeah. I think this case really highlights sort of this sort of epitomizes the primary care experience where, they're coming in for something else. We identify that alcohol is contributing to that. They're not ready to make a change. And so we talk about how they can drink less to reduce their risk or their harm. I think that's, really a good case in terms of that. I think we've all seen that in primary care. I have a patient that I'm working with right now that's very similar. And it wasn't until just like last week, he has his binge pattern and, he wants to drink in moderation. And I don't think that that's possible for him because he's shown that he struggles for that, but that's where we're working on. And he finally said, yes, last week, like, it's not fair that I can't drink like everybody else, but I'm learning that this is something that I can't do. And that's usually where people get to after they slowly try, they reduce their harm, they keep trying, they keep having negative impacts from it, whether it's work or relationships or health. And then they come to this realization like, this isn't as easy for me as I thought it was. So hopefully you can get to that point with a lot of folks in primary care.
And just to also pull from some of the things Kyle was mentioning earlier, I didn't write in this particular slide, but this gentleman had 2 issues that were promoting his drinking. One was that he was actually being verbally abused by his wife at home and humiliated. So drinking was a way for him to numb and escape. And he was also the main caregiver of their 2 kids at home while she went to work. So I think just pulling from those, one, social determinants that, intimate partner violence, right, could be happening. And 2, my own gender biases in this case, right? This guy was a male. I didn't initially expect that to be, IPV to be as a main cause. I also didn't, expect him to be the main caregiver, right? And so those were all my own biases I had to reflect upon and, check on.
Yeah.
All right.
I was going to talk here real quickly. I'm on the advisory board for a project here at OHSU through the Oprah Network, and it's called Antecedent. It's the Partnership to Enhance Alcohol Screening, Treatment, and Intervention. So this is a, let me look at my notes here real quick so I make sure I talk about them correctly. It's a 3-year project where the goal is to support primary care clinics in Oregon with implementation of interventions of unhealthy alcohol use. So again, why? Because Oregon ranks so highly in the per capita cost. You're eligible. All family medicine and internal medicine clinics in Oregon are eligible, and they support their plan, and their goal is to support 150 primary care clinics with a 15-month data reporting on and clinic workflows around integrating expert into routine care. So helping build workflows and identifying areas of improvement with screening and intervention. And it aligns with the CCO incentive metrics around expert. They're recruiting now through February of next year, and they have sort of like phased entry points. And here's the contact information if you or your clinic is interested in getting more information from them. Here's the principal investigators. Let's go to the next slide, 'cause I think I have a few more just kind of talking a little bit about what they're doing. And so they're, like I mentioned, aligned with the CCO expert metrics to address the unhealthy alcohol use. It's free, it's customizable. They have flexible start dates, so they're starting people in quarterly batches, and they promotes a patient-centered care. And so here they're sort of talking about optional support versus the foundational and entry support and exit support. So they're kind of giving everybody sort of this foundational support around baseline assessments and identifying needs. And then they have like a sort of like a menu of options or optional support that you can engage in. And then sort of like exit assessments and talking about, you know, what's changed in the workflow and where the work has gone over the course of their support. And so the optional supports are monthly practice facilitation and coaching, access to the Oregon Echo Network, academic detailing, access to HIT support for EHR functionality, and access to motivational interviewing training. And so they provide a lot of support, a lot of guidance, and can give you feedback as well. I think so. As the advisory board, we've also been recommending that they find ways to allow clinics to share ideas with each other as well, and finding out kind of what works in one place and doesn't work in the other place. And so it's sort of a learning collaborative in that sense. And I think we're at the end there.
All right. Thank you for your attention. And then we'll glad to see you at the Q&A.
Yes, thank you very much. And hopefully this was helpful for you.